Good morning, everybody. Welcome to the March 19th, 2026 meeting of the Maternal Health Access and Birthing Patient Safety Task Force. I'm Christina Alonso from the Department of Public Health, serving as co-lead with Dr. McGregor, my esteemed colleague on this task force. And I want to just welcome everybody. Thank you all for taking the time this morning to be here and to continue following the important work that this task force is doing. I also want to thank the task force members for your continued participation, all of the thinking and strategizing that we've done over the past couple of months to get us where we are today that we will be revealing in a few moments. Thank you all for the time that you take to think deeply from where you sit and from your experience and your professional space on how we can really tackle this issue in a way that's meaningful and feasible for everybody. And of course, I want to note all of the hard work that has gone into preparing the report and the recommendations and getting us to where we are today. We have a very extensive and comprehensive draft of the report, and we have a series of recommendations that we'll be talking through today. And it's been such an honor to be part of this process because of the amount of amazing brains, people, and thinking that's gone behind these recommendations, both within the Department of Public Health, the Health Policy Commission, and other folks that have just generally donated their time to help us understand these systems and get us to where we are today. And so we have some really deep work to do today regarding the recommendations, because we're going to make some recommendations that are going to hopefully shift the system so that maternal health access improves and that safety improves, and that we can start to really break down how to avoid closures and make sure that the maternal health facilities that are open are relevant and really hold true to the quality and the values, and lead with equity, which is what we need the most right now. And so with that, I'm going to pass it to Dr. McGregor to open us up.
All right. Thank you so much, Dr. Alonso, and good morning, everyone. And also good morning to those of you tuning in on the live stream. My name is Alicia McGregor, and I'm a co-chair of this task force. And I've had the privilege of working alongside Dr. Alonso, as well as all of the wonderful team members within HPC and the Department of Public Health, and the amazing members of this task force. And we've reached an exciting point in this work today. And I want to echo Dr. Alonso's thanks to each of you on the task force for your commitment to this work. In addition to the work that you do in each of your organizations and in your communities, and especially right now, as we're at a time when federal policies are threatening reproductive health equity and equitable access to care more broadly, the work that we're doing here today is extremely important to ensure that Massachusetts becomes an even safer place to carry a pregnancy and to give birth, and that's the case across all communities in our Commonwealth. And we're reaching the finish line today, or we're nearing the finish line today, I should say. And I'm excited to discuss the draft policy recommendations that we have that are based on the task force's research findings and based on conversations with each of you and with many others who've provided and lent their support. A reminder that this is the last step before we finalize the task force's report. And so Dr. Alonso and I are looking forward to hearing your feedback and to, each of us weighing in throughout today's meeting. Thanks in advance to each of you for reviewing the recommendations prior to this meeting. And thanks to all of you for getting started with reading the report. I know it's a big report. It's full of very dense findings, but it's very good stuff, and I'm really proud of everyone who's played a part in it. All right, so for the order of today's meeting, following a brief summary of the task force's key findings, we're going to open it up to what we hope will be a robust and fruitful discussion of the draft recommendations, And this discussion process will make up the bulk of our conversation today. Um, er, I think our first order, right, before we get to the approval of last meeting's minutes, I just want to also note that our goal in general before moving to the next stage is to gather any additional feedback and reflections that you all have so that we can incorporate it. But you'll also have a chance to sort of send additional comments as well, in addition to what we cover today. So this is not the last opportunity. And all right, so before we dive in, let's get to the approval of minutes. So our first order of business is to approve the minutes from our last task force meeting, which took place on December 9th, 2025. Votes cast during a remote meeting must be taken by roll call. So when your name is called, please vote yay or nay. And we'll call on each of you. So at this time, I'd like to call for a motion to vote. Is there a motion?
I'll move that.
All right, is there a second?
A second.
All right, thank you so much. And so I'll call on each member present to vote today, starting with Dr. Christina Alonso.
Yay.
All right, Nashira Burrell.
I don't think she's
I
here.
don't think she's here. Okay. Amy Gagnon.
Yay.
All right. Dr. Godwin Osei-Poku.
Yay.
All right. Dr. Kristen Price.
Yay.
Dr. Sarah Shields.
Yay.
Lee Simons.
Yay.
All right. And Dr. Huang Tro.
Yay.
Huang Tru. Apologies. All right. Thank you so much. So at this time, we will move to the Maternal Health Task Force key findings. So at previous meetings, we've discussed the key findings, both qualitative and quantitative, that have come from the task force's research. And we've discussed them in some level of detail. But today we'll be highlighting sort of the high level key findings from the report, because it's a pretty hefty report, just to contextualize our discussion of evidence-based policy recommendations today. So with that, I'll now turn it over to Kara Vidal from the HPC Office of Health Resource Planning to outline the key findings. Thank you, Kara.
Great, thank you so much. Can everybody hear me okay? Wonderful. Okay, good morning, everyone. Happy to be here today to provide this quick summary. And I will do that in the same order that we have organized the report chapters. So we'll start with an overview of Massachusetts births and birthing people, move next to a discussion of our maternity care supply and capacity. We'll then talk about the findings specifically related to maternity unit closures that took place from 2014 through 2023, and then move to chapter 4, which was about birth centers. Next slide, please. Great, thank you. So starting with chapter 1, overview of Massachusetts births and birthing people, we did find, as others have reported in the past, that the Commonwealth's birth rate has declined by 10% over the last decade. We saw not only a decline in the birth rate, but also in the total number of births, so decreasing births in the Commonwealth. We also found, when looking at the demographic and clinical profiles of birthing people, that Massachusetts birthing people compared to a decade ago are more racially and ethnically diverse as a cohort. They are older and they are more clinically complex. We looked at a few specific measures also of utilization. and found on the first, prenatal care adequacy, that prenatal care adequacy rates are falling across the Commonwealth. This was true in nearly all regions of the Commonwealth and across all demographic groups. A very concerning finding, I think. And we also found that C-section rates, our other utilization measure, are rising, even for low-risk births for which a C-section is less likely to be indicated, and especially among Black and Hispanic birthing people. I think the group spent quite a bit of time talking about those findings at the September or October meeting of this task force. We also wanted to look at outcome measures, and not on the slide here, but important to note that Massachusetts has very good performance on certain outcome measures. Our maternal and infant mortality rates, for example, are quite low. Our preterm and low birth weight birth outcomes are better than the US average. But on some other measures, particularly for severe maternal morbidity and for C-section rates, Massachusetts actually performs worse than the US average. And then finally, this is not a new finding, of course, but really important to emphasize because it was a pattern across, I think, every measure that we looked at. There continue to be persistent and ubiquitous inequities in maternal health outcomes, especially for Black, non-Hispanic, Hispanic, and publicly insured birthing people. Next slide, please. Okay, so turning to our maternity care supply and capacity, here we were focusing on hospital maternity care and the maternal health workforce. So starting with hospital care, there have been closures of maternity units, as you well know, and as was partially the impetus for this task force. So we know that there's been a decline in the number of hospitals offering maternity services. We also know that the number of obstetric beds has decreased during the same time. However, if you were to look at that in a volume adjusted way, so the number of obstetric beds per 1,000 maternity bed days per utilization, that measure has actually remained flat over time. And that is because the decrease in beds has paralleled that decrease in births that we mentioned on the last slide. We also looked at drive times. We looked at the percent of the population within a 30-minute drive time to the nearest maternity hospital. We are not aware, I do not think there exists a standard of what that drive time should be, but the American College of Obstetrics and Gynecology have used a 30-minute drive time in the past, so we use that as well. And we found that as of 2024, almost all of the Massachusetts population, 98%, are within that 30-minute drive time. I think ACOG has also done maybe a 2-hour drive time, and obviously we are well within that. We looked at maternity unit occupancy rates as well. That is comparable to what you could think of as a general hospital occupancy rate. That's sort of bed days available, or rather the total number of bed days that the hospital could provide in relation to the number of days it is providing. So we did a specific calculation for maternity units, looking at maternity patients over maternity bed days available. We found that occupancy rates are generally within accepted capacity standards. Though when we segmented that by hospital type and looked at AMCs apart from community hospitals, we found that the AMCs had noticeably higher occupancy rates than our community hospitals. Massachusetts hospitals generally perform well on the maternity quality measures that we had data available for, especially episiotomy rates and early elective delivery rates. Performance was more mixed for low-risk C-sections, and as noted, there are persistent inequities in C-section rates by race and ethnicity. And then finally, the last bullet on hospital supply here, we did look at measures of volume, at measures of payer mix, and at measures of price. We have individual analyses of those in the report, but I think really importantly, the constellation of those factors can have a really significant impact on a hospital's ability to cover the costs of their maternity services. So in particular, low volume, high public payer mix, and low prices, that constellation is a significant challenge for hospitals. In terms of the workforce, we found that the size of the OBGYN workforce has been stable over the last decade. Our CNM workforce has grown substantially. Those are state level measures. If you looked regionally or by hospital, you would see variation in supply rates per thousand by different regions, or the use of OB/GYNs versus CNMs in deliveries by hospital, for example. We also found that our maternal health workforce is less diverse by race and ethnicity than our birthing population. Next slide, please. Okay, in the third chapter, we were looking specifically at closures, and we started by trying to understand if there were any measures or factors that looked different for our closure cohort of hospitals versus similar hospitals that did not close, or what we called our non-closure cohort. So for this analysis, we were looking at 7 closures. We did not include in this analysis the 2 closures that occurred because of natural disasters, so that the Norwood flood and the Brockton temporary closure due to the fire, those were not included here because we know why those closures occurred. So looking at the other 7 closures, we compared some factors for the closure hospitals with those same factors at community hospitals that did not close their maternity services, and found that there were some differences. Closure hospitals had lower volume, they had lower maternity unit occupancy rates, and they had lower prices. And I think we did not find those results surprising. As we said on the last slide, we had already explored in chapter 2 that the constellation of low prices, low occupancy rates, and a high public payer mix, for example, can be challenging for the sustainability of a service. We also found that closure hospitals had a higher public payer mix. We next moved to looking at impacts of closures. And so we mainly did this by drawing a service area around each of the closure hospitals and looking at changes in outcomes for patients living in that service area before and after the closure. Unsurprisingly, we found that patients had longer drive times after a closure occurred. I think that is to be expected. We also tried to see if we saw differences in a series of different outcomes based on what others in the literature have found. So we looked at 39-week induction rates, low-risk C-section rates, severe maternal morbidity rates, and preterm birth rates. We did not find any pattern in our data showing that those rates changed for patients living in a closure service area. However, we also conducted qualitative interviews and also reviewed transcripts from the essential service closure hearings that DPH conducts when a closure occurs. And so heard a little bit about other potential results of a closure through those venues, and in particular heard about the continuity of care disruptions that take place when a closure occurs, and also a serious loss of community trust in that institution when they close what the community perceives to be a very needed and valuable service. We heard other topics as well. Some pointed to the fact that if a hospital is struggling financially and closing the maternity unit helps stave off some financial concern, that can benefit the community if those funds are reinvested in other high-value services. And then finally, we wanted to understand where patients go for care after their local hospital closes, and we call that the recipient hospital, who receives the volume of patients from that service area. And we wanted to see if recipient hospitals were different from closure hospitals in any meaningful way. We found nothing that raised significant concern for us. We found that recipient hospitals tend to have higher volume and higher occupancy rates, and that they had experienced treating patients with the same sort of obstetric risk level, which I think eased any concern that patients were maybe going to hospitals that wouldn't have sort of the same level of experience caring for high-need patients. We also compared the closure hospitals and the recipient hospitals on the representativeness indices that we looked at. So we have a Black non-Hispanic representativeness index, a public insurance representativeness index, and a Hispanic representativeness index. In general, we found that the recipient hospitals had a similar or lower Black non-Hispanic representativeness index and public insurance representativeness index. So, possibly lower, but in some cases, similar levels. They did have a lower Hispanic representativeness index, suggesting that the recipient hospitals treat sort of a lower percentage of Hispanic patients relative to the total mix of Hispanic patients in their service area. And on the last slide, thank you so much. This is chapter 4. This is birth centers. Found as well supported by a large body of literature that midwife-led birth centers are a high quality alternative to hospital care for certain low risk birthing people. But in Massachusetts, access and capacity to those birth centers is quite limited. There is one open birth center right now, though there are others that are aiming to reopen or that are aiming to open for the first time that will hopefully increase that access and that capacity soon. We heard quite a bit in qualitative interviews about some of the challenges for birth centers, startup funding being a key impediment that was identified, and the ability for birth centers to cover their costs under their current reimbursement levels was a notable theme from those interviews, as well as recruiting and retaining midwives. So staffing can be a challenge for these birth centers, and administrative complexities as well are also mentioned. And just generally the continued predominance of the hospital model of maternity care, for patients, for policymakers, for clinicians across the board. There may be an opportunity there for more education and awareness of some of the value of birth centers and the opportunities that they present as high quality, often lower cost options for birthing people. And that was the summary of our key findings.
All right. Thank you so much, Kara. Can folks hear me and see me? Thank you so much, Kara, for that wonderful presentation and also for your leadership in this effort and the leadership of the OHRP on this report. It's been tremendous. So thank you very much. So at this time, we will turn to, I think, which will be the most exciting and fun part of the meeting, which has been exciting already. And that's to discuss the policy recommendations. And this is where we'll spend most of our time. So as we open up the conversation on the policy recommendations, we'd like to note that given that we have limited time and we want to sort of make the best use of this time we have together, we're going to focus on sort of the 7 main focus areas that the policy recommendations are organized by. And we'll start by asking each of you whether or not you have a specific issue to flag in any of these areas, because if not, we can move relatively quickly through any sections where there weren't any concerns or feedback and spend relatively more time in the other areas, if that makes sense. So we are showing the 7 focus areas of the policy recommendations here, and they include the section on maternal health access and outcomes, the piece on maternity care sustainability, and various payment reforms and other reforms suggested there. The section on hospital maternity units specifically, and maternity unit closures. The section 5 on maternal health workforce, 6 on freestanding birth centers, and 7 recommendations around patient awareness and choice. So we'll start by going through each of these, and please, if you have any particular feedback or any concerns with any of these areas, please feel free to use the raise hand function, or to just unmute yourself and weigh in. So I'll go back to section number 1, maternal health access and outcomes.
Were you going to read through them? I had a comment on this one, a brief comment.
Okay, so just so I'm getting the order of events right, and Dr. Alonso, if you could weigh into and here, because I think I just to make sure I have this right. So we're asking folks to kind of first flag that you have a comment on that area, and then we'll come back. Is that right?
Yeah, it might be helpful if we go back a slide, whoever's controlling the deck, back, there we go. Yeah. And so we just kind of wanted to have a roll call because there might be of the 7 thematic areas, there might be 1 or 2 areas where everybody's totally satisfied and absolutely loves the recommendations and has no feedback. And we just wanted to note that. And so if we can just go through right now and ask, if any of you have comments on sections 1, 2, 3, 4, 5, 6, 7, and then we'll know in terms of time that we need to deep dive into each one of these. And if you have comments on all 7, it's absolutely fine. That's what we're here to do today. So I'll start with section 1. Do people have comments, edits, and questions about section 1? Going once, going twice.
I see
I think a
2
couple
raised
of
hands.
us, yeah.
Okay, I'm not seeing hands. Okay, great. Okay, so there are, yes. 1 is a yeah. Okay, and on section 2, are there comments, questions, edits, concerns? I can't see hands, so.
Hands
Yeah.
are raised. Yes.
Okay, yeah, perfect. Thank you, David. Section 3, are there questions, concerns, edits about hospital maternity units?
Lee, yes.
Is that a new hand?
Yes,
Or
sorry.
Yep.
They're not
why
all
I
long
said-
comments, but I do have comments.
I'm all about comments and participation. 4, section 4.
Yep.
Okay, section 5. Yes.
Yep.
Okay, section 6. Any comments? I can only see you, David. So if you nod, I'm going to take that as a yes. Any comments on birth centers?
Sarah?
Dr. Shields, is your hand still up for this one, or is that?
Yes, I just have a
Yep.
slight comment on this one, thanks.
Great. And then section 7, patient awareness and choice. Do we have comments, questions, edits?
No hands are raised, but maybe we'll see if we have time on that one. Yep.
See what
1
time
hand.
it is at section 7. All right, Dr. McGregor, I'm going to toss it back over to you and we can deep dive into section 1, maternal health access and outcomes.
All right, great. So who's advancing slides? Thank you. All right, so Lee, I saw your hand up for this one, and I think also Dr. Shields. Which one of the recommendations for this section did you want to raise at first?
I had the same comment for 1 and 4, and then a separate one for 5.
Okay. All right. So 1 and 4. So 1 is around establishing goals for improving maternal health and reducing access and outcome disparities. So yes, please feel free to share your feedback. I think folks can see what's written here on the slide. I don't know if folks need me to go over it again.
Oh, sorry.
No, go for it.
I was going to say, I would just suggest alignment with Pinquin and Mass Health on some of the work they're doing here, just to, and this is similar to my comment for number 4, just to not create lots of similar but disparate initiatives and measures that are difficult for providers. Everyone wants to work moving forward in this, and not kind of have work streams that are slightly different and then hard to, with tapped workforces, make progress because everything's just like a tiny bit different.
Right. Absolutely. Absolutely. That makes a lot of sense and is important. Was that Dr. Alonso, was that kind of implied here as well? Because I know we do definitely mention
I think in
Penguin.
a later one there was
And the-
reference to other agencies, but this one not.
Okay, great suggestion to explicitly mention that here. And then for the other recommendations that you had
For
feedback
number
on.
4 was similar,
Okay,
but for that one this one does include Pinquin and the Betsy Lehman Center, but I would just also include um, um, Mass Health in the plans, aligning, like trying to align those incentives so folks aren't working towards slightly different ones for every payer.
okay. Great. And you said 4 and then it was just
And-
1 and 4?
And then 5 was a different point. So I don't know if you want to go there now or if
Or if we want to have folks. Okay, so does anyone disagree with this feedback or have any particular or anything to add on this note?
I would
Dr.
just say from Penguin's perspective, we totally agree with Lee's suggestion of adding it, especially to number 1.
Okay. I think that sounds great. And I think it makes sense to explicitly call that out. So thank you so much, Lee. Dr. Shields, I
Yeah,
saw you
thanks.
unmute.
I agree with the issue about maybe even on many of these suggestions here to deliberately include Penguin listed. And then just because I forgot what BLC stood for, just to remember to spell that out. But the bigger picture issue I had was that it struck me that some of these issues are things that we've already had reports on in the past, and I'm wondering 2 questions. What are we suggesting that's going to be different than what's been done in the past? And how can we help DPH do these reports in a timely way? Because one of the concerns has over the years has been for some things with public dashboard outcome stuff is that we're a few years behind schedule. And so can we sort of call out the question of timeliness, like supporting DPH to be able to have timely reports?
I think that's an excellent point. I actually had the same feedback around some of this we already know to some extent. We've already done work on. And so actually, Dr. Alonso, I'm gonna let you answer that question.
I think it could be noted. Let's think about how we include that in the sort of the piece behind some of these of if we want this thing to happen, what needs to happen so that that can happen in several of these. Some of it has to do with funding, some of it has to do with staffing. You know, there's layers of complexity. And so I think that's something that we can go through carefully and edit and make sure that the piece behind getting this thing done is called out, whatever the item is, be it a public dashboard or, you know, supporting some sort of initiative. I will say that I think that we were careful in the layers of editing we did both within DPH, with our partners within Health Policy Commission, about making sure that the recommendations that we're making are things that aren't already happening or won't be happening in the next few months. Because we do acknowledge that this is a document that we hope will last several years and we'll be able to continuously go back to it. So we were careful to take out things, for example, I'm just going to give an example, like, you know, support doula certification. We are going to launch doula certification in the next few weeks, so we're not going to include that in the report. Okay. There is no section on doulas, but I'm using that as an example because that's coming soon. I hope that helps to clarify and also to kind of understand the process thinking around some of the things that you might say, oh, but we need to do this because it's about to happen. We took it out. Okay.
Also to add around the point about timeliness is that, we tried to include some deadlines around each of these recommendations. Or so, for example, 4A, that DPH and Penguin should establish this dashboard by 2028. And, there are different suggested timelines in each of these recommendations. And, would love to hear any feedback on the reasonableness of these timelines, and whether folks think maybe some of them aren't happening quickly enough. But I think we brought those in to try to make these goals that are, where we actually have a to-do item, and we can hold ourselves accountable.
Yeah, thanks. That wasn't exactly what I meant by timeliness. I meant sort of the ongoing timeliness of the data that gets put up into the
Oh,
dashboard.
okay, good point. You were saying that that Massachusetts has a bit more of a lag than other states, you think?
Oh, I don't know how our lag compares with other states, but it does feel like there's a lag time. So
Okay. Well, we can definitely find a way to bring that in here. Do folks want to? Oh, go ahead, Dr. Shields.
sorry, no, I had one other comment on section 4. On the incentivizing and rewarding providers. I guess I would want to make sure that, and maybe this is in the more detailed report than the sort of high level summary part, but that it's meaningfully improving healthcare outcomes, so that, there's not like I hate to use this word, but it's all I can come up with, like a gamification of that it's a meaningful process, and that, if it's going to be a pay for performance, that we make the performance meaningful.
Yes. Great point. Just on two of the points that you just made, I wondered whether the task force would be interested in getting a little bit more clarity, or potentially digging a little bit deeper, because around the lag, I wonder if anyone around the table knows the reasons for the lag, and potentially how we might sort of get data updated more quickly. And when you say lag, I don't want to sort of call on anyone, but I see
Yeah.
Dr. Godwin has unmuted.
I can speak. I mean, we at the BLC have sort of some experience with the data lag and stuff like that. So with SMM, at least we are now able to see SMM within 8 weeks of the event. Now, if you look at DPH's reporting on SMM, maybe 2 years out. So when Dr. Shields mentions that she's thinking about, could it be 6 months, could it be 3 months data that is put out there, so that we're in 2026, could we have data that shows December of 2025, that shows where we are. So especially for quality improvement, for good surveillance, you want to have the data more rapidly uploaded so they can see how you're progressing and stuff like that. That would also, most of the data we use comes from CHIA. So Dr. Trios here, I think we have developed a process where the data can be analyzed more quickly. And maybe there could be a way that we fuse that into how DPH will sort of build this dashboard, how frequently they get the data, and who at DPH should be responsible for doing this. I realize DPH is pretty large, so if we could call out the specific department or unit or whatever that should be responsible for coordinating this, putting together this dashboard, also in partnership with CHIA and others who are custodians of the data.
I think to add to that, and I think it depends also on the type of data one's looking for our from the hospital side, in terms of our case mix data, we do get quarterly updates on the case mix, but they're preliminary. So in a public reporting, I think there's a decision to be made, right, in terms of what this group are comfortable with using preliminary versus final data. Final data would set us probably almost a year, behind in terms of data lag usually. With our all payers claim data set, because of the claims, just the processing, you would have at least a 3 to 6 months run out. It's just a nature of that data. So I think there is an aspect that this group could consider in terms of what level of precision and what level of final data would we be comfortable with in measuring these outcomes.
Okay, thank you to you both. That's a great point. So I wonder if there would be an interest in having preliminary data for certain kind of urgent outcomes, and then doing a follow-up finalized report. This is something that can be discussed in future conversations. I know that at least one of these recommendations has the recommendation to create another committee task force to work on this. All right. Okay, so next point.
Lee.
And yeah, and 1 on 5. I think very much agree with this. I would just, it speaks to investing in reducing regulatory barriers. I would add like reimbursement barriers too. I think in point A, particularly given the monies from the federal rural transformation piece and the synergies that could happen there, I might also add mobile integrated health and hospital at home as a vehicle that could do some of this work. And then on the second point for B and remote patient monitoring, I know there's some variation in how that is covered and reimbursed. So I would add that to that point. And then I also, this is my colleague's expertise and not mine, but my understanding is there's some remote patient monitoring programs that, the model is based on RN and clinical pharmacist workforce. And some payers do not allow those types to bill for that care, but similar or other provider types could bill for the same type of care that's delivered. So I think just looking at barriers there specifically, in particular, if we're looking at using this care in more rural areas.
Those sound great. Do any other members have any feedback or suggestions? Dr. Price?
I can speak to this from the remote blood pressure monitoring perspective. That definitely was an issue to begin with one of the programs that is being supported by a HRSA grant. However, they did find a workaround there. So it's kind of like flu shots where we all get our flu shot from a nurse, but the nurse is not able to bill Medicaid, but it's under a standing physician order. So there are workarounds, but I do agree, Lee, like if we're going to expand these to be able to consider additional healthcare workers that could potentially get reimbursed, that would be helpful.
I have a question about the remote maternal mental health care. Are we thinking about telehealth for mental health care? Are we thinking about the patient entering almost screening questionnaire remotely? I'm just trying to understand what that is, what's included.
So currently we have a pretty, I don't know if to call it robust, but a very functional system through MCPAP for Moms, where because we lack perinatal psychiatric professionals, McPat for Moms is a hotline where professionals can call in and say, I have a patient that has this diagnosis, these symptoms, help me with the medication, with the treatment plan, all that. McPat for Moms is trying to first become much more available, expand, et cetera. And so it's a very promising model based on McPAP itself that was developed for child psychiatric support as well. And so it's sort of thinking about, just as Dr. Price was saying, that we have some systems that have proven to work. How can we expand them, make them accessible, make them available, make sure they're staffed, funded, so that everybody's getting the care they need in the moment? It's not so much thinking about therapy online, which already exists and is reimbursed. It's more about the system to support mental health as a structure.
Thank you.
All right, great. Dr. Shields?
Yeah, I did have a question about that though, because I do think there's a shortage even of the telehealth mental health care available. And so to sort of support, maybe that comes up in some of the other things around the workforce part, but I don't think it's just about providers having access to talk to somebody who specializes and can advise them, but it's also about the birthing people themselves having access to therapy.
It's a great point. Dr. Price?
The only other thing I would say, especially when it comes to the mental health piece, is that we know from our maternal mortality review committee that the majority of maternal deaths do occur because of substance use and mental health, but they're also occurring often late in the postpartum period. So just also, we keep mentioning maternal care, and I think that's important, but I also think that so the deaths that we're seeing are often when patients are no longer getting their maternal care. So we should also think about the pediatric and primary care aspects as well.
Yes, thank you so much for emphasizing that. Actually, on the topic of the Maternal Mortality Review Committee, that also relates to kind of the data lag question too. And there's parameters around which, the data can actually be legally made public or even made available to us, right? Or maybe Dr. True or Dr. Osei-Poku, do you know? Or Dr. Alonso, actually.
So I think with maternal mortality, we're always going to have a lag in first the abstraction of the case, the investigation of actually presenting the case to the committee, and then there's legal steps, there's collecting the documents and all of that. Massachusetts is remarkably on time in terms of review. Like, we review all of the cases where we're reviewing in a timely way. We're not reviewing cases from 3 years ago where our lag time is very short. And then there's an issue around the approvals of the reporting. So that also, it needs to be approved by DPH, it needs to be approved by EHS and also the legislature. So there's layers of it. I think too, with maternal mortality, we're talking about, such a deep impact outcome. And then dashboards are looking more of, hemorrhages and ICU stays and things that are, we're looking at sort of different trends there. I almost feel like they're two separate things. But I think looking into, is there any way that the maternal mortality reports can be published faster, just as a systemic process, without removing how thorough the cases are reviewed, right?
Right, but potentially data on postpartum hemorrhage or any of the other kind of case-specific data that a birthing patient might experience could be available earlier.
Through the claims data, right? Through CHIA.
Oh,
Yeah, as we were discussing. Yeah.
And
The
Dr.
the only
Frank?
other the only other point I'd make is that because the MMRC reviews cases up to 1 year postpartum, so they already have to wait a full year before they can even identify the cases. So if there's a maternal death at 11 months, that needs to be captured before they can even start reviewing the cases.
Okay. Thank you for that. All right. Well, definitely a lot to consider on the first focus area. Are we ready to move on to the second area, maternity care sustainability? All right, thank you so much. Okay, so under this focus area, we have three high-level recommendations, which involve assessing the cost of care across all maternity settings, creating a maternity care stabilization fund, and exploring options to reduce the burden of malpractice premiums for maternity care providers. So important themes that came out of the report and came out of looking at the data and interviewing high level and folks and clinicians across care settings. This is the attempt to try to really understand and get a sense of the actual costs of providing care during childbirth and postpartum. And also the maternity care stabilization fund is sort of a concept to improve the sustainability of especially what we're thinking of as maternity units that are, in some respects critical to our most marginalized populations. And then finally, the question around malpractice premiums, which are a considerable burden, or can be a considerable burden in low volume settings. All right, did folks want to start weighing in here? I know Lee, you had your hand up on this one.
I realize I mistakenly raised my hand on this one. I don't have comments on this one.
Oh, no
I
worries.
retract my hand.
No worries. Dr. Shields?
Yeah, I just had a question on number 8 because I appreciate that anytime we talk about maternity care, there's always the background issue of malpractice, but I hadn't necessarily seen that in the data from the other, the qualitative interviews or whatever. So I was just surprised to see that come up, and I wondered, how if there could be a little bit more fleshing out of that issue in the sort of summary of the findings itself, if we're going to make a recommendation about it. So.
Yes, excellent point. I guess we didn't, that wasn't featured in a major way in the report, but certainly an issue that comes up quite a bit. Dr. Alonso, did you want to add anything there, or?
Just kept myself unmuted so I can jump in when I need to.
All right.
Nothing to say.
So did any members have any thoughts on these recommendations?
Yeah, I just have I like the idea of the stabilization fund, just clarifying questions. How large will the stabilization fund be, and how are we defining demonstrated need?
So the questions are, how large will the fund be, and how will
Are we defining demonstrated need?
Yes, excellent question. So definitely details to be determined, including how will we fundraise for it?
Sorry, yeah.
So that's something that those details aren't included in the recommendations as of yet, but will remain to be determined. Should we add language around how this should be determined? Nashira?
Thanks. Yeah, no, I I want to hear the answer to your question, and I just wanted to echo that question and wonder if we can also put some language, and it might be that the language belongs in the legislation, which is the next step, but that there is some way to counter the built-in structural inequity between a hospital going for fund and a birth center going for the fund, right? So I can tell stories about the pattern of how funds get distributed differently, but I would just want to make sure that that is considered. And again, that might be language that needs to end up in the legislation later, but yeah.
Absolutely. Excellent point. Excellent point. And I think that also raises whether demonstrated need, whether organizations actually have to demonstrate it through through some proposal process or application process, or whether that's something that's determined based on certain factors related to the organization's financing or any shifts in access to equipment or whatever the case may be. So do folks have any ideas about what should be included here, Nashira?
Yeah, sorry, one more thought. And there might be folks who know more about this than I do, but I think when it comes to provider salaries and bonuses, we want to make sure that that is not what is also being billed to insurance. And so there's just got to be a way to kind of figure out how those funds get released and are not covering providers whose care is also being billed to insurance. So again, I trust that we can figure that out, but I think naming provider salaries and bonuses in there could be a sticking point.
Mm. That's a great point. It's a great point. David, did you want to weigh in here?
Just to offer an observation for the task force, as we've been working to support another task force, the primary care task force, and wrestling with, at what level do we make these recommendations and how much detail to include. It's tricky and it's hard. And so we have often come to a place of, what are the principles? What are the broad parameters that we're recommending to the legislature, and have avoided trying to, write the legislation in the recommendations, as Nashira was alluding to. And so, thinking about, what are the principles that are guiding these recommendations? What are the principles that we're wanting to have this fund support and do. And so, as Nashira, you were talking about the kind of a principle of that kind of equitable access to funds, right? And from between birth centers and hospitals. And so encourage people to think, not about, defining necessarily each one of these terms, but giving some guidance about what are the core ideas that we're trying to recommend.
Right. Thanks so much, David. So with that in mind, do folks think that this sort of accurately conveys the core ideas around a maternity care stabilization fund that we should be aspiring toward?
Is it all right to throw in either an adjective or an adverb that says equitable or equitably somewhere?
Oh, absolutely. I didn't even recognize that wasn't there.
Maybe to equitably support.
Mm.
What about scholarship programs too? That can have different effects on the pipeline than loan repayment.
Mm. Scholarship programs for any particular type of clinician, or potentially for the support of people entering CPM or CNM training?
Yeah, I think RN programs too.
Mm-hmm. All right. It's a great idea. Nashira?
It's another kind of thought reflection on this. I feel like a stabilization, or might even call it a sustainability fund, it could be trying to meet multiple objectives, and in implementation is going to mean that a lot of hospitals and birth centers and potentially birth centers in the pipeline would be competing for it. And it seems like it's trying to do a lot between workforce development, retention, precepting, salary. So I'm just wondering if someone could speak to like the real clear objective, because when I hear stabilization fund, I'm thinking about the maternity units that were closing and that have closed, and if they got, and we don't want them to get to that crisis moment, but I'm thinking about kind of a fund that responds before a closure and could have saved the North Shore Birth Center, or could have saved, you know, one of the 12 maternity wards that closed. And so I guess I'm just wondering for a little distinction between like a stabilization fund and what is really needed. It's a big base of resource for all of the other things. And I'm feeling like there's different objectives in here that we might be trying to meet in one fund, that the implementation of which in the legislature could end up being more watered down than our intention.
Yeah, that's a really excellent point. And I think it also gets to what Godwin just suggested around the size. What's the size of the fund? What would be the size of this fund? Those details aren't there, but it would definitely need to be large enough to meet its stated goals. But are you suggesting then that potentially we should maybe narrow the scope of the fund, or just make it a big fund?
Yeah, right. I don't know that I'm suggesting to narrow. I wonder if it's two recommendations. There's like there's there's like a need to have a fund and some state resource to that. And then I'm feeling like the stabilization and the there's almost an emergency fund or something that helps to stabilize a unit. And that's also not sustainable, right? The stabilization of it is, or the instability is related to payers. And so I guess I guess I just want to hear a little bit for those who worked on this, kind of what objective are we trying to meet with the fund? And if we can be more pointed in this, and maybe there's another recommendation. So I'm not making a recommendation on Dr. McGregor to reduce yet or narrow. I just wanted to hear a little bit, because we're trying to do a lot with this one.
I know we're trying to achieve our dreams here, but I think this is where it starts, right? I didn't sort of do the first draft of this one, even though I very much support this and have discussed, proposed similar ideas in other spaces and in other work. I think it's something that needs to be large. I think it needs to be, the details around whether it's a grant fund or a zero interest or low interest loan fund is not here, but I think it should be a grant fund. I think that it should also address the urgent issues facing our maternity care system, which are many, but they certainly include having the revenues and capital available in maternity units and for freestanding birth centers to keep these entities operational and keep them able to provide the highest quality care, and to also strengthen the workforce. So I think we need to be doing those two things at now, or else the crisis that we're facing is going to continue to worsen. And potentially we can make those two separate funds, if that's something that we think could get through legislatively in a way that's more meaningful. Or we could make it one large fund, I think, and leave it to the legislature to figure out how to fund it, where the money is going to come from. So, do folks have any other thoughts or ideas here?
It does seem like the workforce issue with scholarships and loan repayment is partially addressed in a later recommendation, and I just wonder if, I mean, it's a piece of stabilization for a unit that's about to close, may need funds to help, incentivize getting the after-hours providers to staff the unit. But I just wonder if, um, this one could be sort of in conjunction with the workforce recommendations that are in the later place.
What does everyone think?
Well, I mean, it's not really, I'm just thinking it, I guess it's just scoping it very well, right? As you said, do we want it to focus only on supporting specific things, or do we want it to be a fund that does everything? So I would just suggest that maybe scoping it well in the recommendation may be a good way to go about it. And scoping it well could also mean several things, but being a bit more focused about what this fund to.
All right.
I think when I'm sorry. When I'm like rereading this recommendation and hearing this conversation, I'm thinking like the language here makes me think of this is kind of like how do we prop up critical access maternity ward? And I'm wondering, is that the scope for this recommendation really versus a later one is really about broader workforce development across the system, right? In terms of we just need to make investment in globally, not just in areas where we know these hospitals may be closing or birthing centers are trying to get there but not getting there. So I'm just wondering what's the balance? I think it does go back to scope, but currently this one is reading to me more and more like, how do we keep critical access point open for maternal population?
Yes, and that's right. That's exactly right. Lee, did you want to add something here?
Yeah, I was just gonna say, kind of to continue on that point, the recommendation in 13D says the legislature should authorize funding from the Maternity Care Stabilization Fund when appropriate to support the temporary operation of essential maternity providers until a comprehensive plan is in place. But I don't feel like that's really referenced in this here.
Right.
And
Okay, so I just want to, I know we should move on in the interest of time, and I think several of you have mentioned the overlaps between recommendations that show up later. So I think, we take that there's different aspects of this maternity care stabilization fund that we'll sort of need to flesh out. And please, if you have any other comments on this particular item, do feel free to email after this discussion, and we'll make sure that they're in the follow-up draft. All right, so with that, let's move on to focus area number 3, which is hospital maternity units. Right, so to open it up, who had feedback on these recommendations?
unsurprisingly, I did. But Dr. Shield, I think you did too. If you want to go first this time.
Sure. I had a question on the issue of the patient access to risk appropriate care. On number 9, the first one, issue A. And just to clarify that insurers need to cover any level of maternal care that someone needs. And, if somebody has an insurance plan that's restricting which hospital they can give birth at and they need care at a higher level hospital, that needs to be addressed. And then the other thing I had was for Um, 10 on reimbursement policies for maternity care to perhaps allude to the upcoming changes in the coding and billing for maternity care with the change of the global fee, to make sure that that's somewhere addressed. So
Yes, thank you so much. And these were definitely written with the change in the global fee in mind. So I'm surprised we didn't put any language in there on that, but I think that's a great point. Lee?
Yeah, I would just say, first of all, I agree on Dr. Shields' points, but then also for 10A, the last sentence, I want to make sure we are recognizing kind of the overall delicate state of provider finances at the moment. I think the most recent CHIA data had like negative 2% margins for hospitals. And so, it's the same facility, even if you're recommending moving. I just want to be recognized, the effects that it could have on destabilizing an entire facility, in it having the desired intent.
And Lee, you're talking about 10A right now?
Yes, that last sentence around maternal health payments should balance increased payments across other service lines. Because if we're talking about individual facilities, it would impact their sustainability, their financial sustainability.
That's a good point.
Especially given what we know from the report about the financial status of hospitals whose units have closed.
The other thing too, and this just occurred to me, is that I wonder if there would be, if public and private payers balance these payments, that this could potentially create a scenario where there's a fear that other service lines will kind of lose reimbursement in favor of increasing payment for maternity. And I wonder if could that inadvertently cause hospitals to want to just let go of maternity. This is but not potentially a little outlandish. David?
Just again, to offer an observation, and this is again something we've been wrestling with in the primary care task force as well, reflecting and recognizing the very real healthcare affordability crisis that the Commonwealth is in, and the fact that so many residents are really struggling to pay for the cost of healthcare. And whenever we're talking about increasing payment, what are the implications of that? I think maybe a suggestion, Lee, that may help assuage some of your concern here would just be not to talk about should balance these payments across other service lines. I think maybe saying that this should be balanced kind of like across total healthcare spending. It's maybe this is maybe too specific in trying to say that it should be balanced kind of within hospital payments, and I don't know that
Yeah.
that's exactly I don't think that was the intent.
Yeah.
And I think
I
it's
would-
kind of, there may be other places in healthcare spending where payers might be able to find
Yes.
efficiencies that is not balancing that off of other hospital service lines. Get what I'm saying?
Yes, that would make me much more comfortable.
Okay.
Right. Okay, thanks for that clarification. All right, any other thoughts on the recommendations around maternity units?
I just had a question on C. I know there's a little bit in the report around the breakdown of professional versus facility fees, particularly between just like the different methodology between Mass Health and the commercial plans. And don't have Dan McHale's background here, but I just don't know that the report flushes out why one may be more preferable than the other.
Well, in the report, we do highlight that for Mass Health, the facility fees for childbirth hospitalizations are generally higher than what commercial payers are paying for it. So that didn't seem to be the area where Mass Health was paying less. So that detail was put in there, I believe, with that in mind. But does anyone else from the HPC team want to
Kara just
weigh in
came.
if I left anything out?
No, that's exactly right. Just to clarify, we did look at and compare differences by hospital in their maternity reimbursement level for a uncomplicated vaginal birth, and found that when you look at the total price, yes, commercial reimburses more for most hospitals than Mass Health. But if you looked just at the facility component, they're actually quite close. And for most hospitals, the Medicaid amount is a little bit higher. So it's really that professional component where the discrepancy exists. So that was exactly where it fed into the recommendation.
Okay. Thank you for your.
But actually, it's a good point, because that's where the disparity exists right now. But who knows over time how that could change. So it could be also a good idea to ensure that we're also keeping an eye on that as well, which, will be part of this ongoing work. All right, so if there are no additional questions, suggestions, feedback on this part.
Just one. D mentions birth centers, and I'm just wondering if we're also having an analysis of the reimbursement for birth centers separately here. Because
You mean separate and apart from the hospital's analysis?
yes, because the case that Kara just said is actually really different for birth centers. There's a much lower facility fee.
Compared to hospitals.
Yes, which is like the thing that tanks birth centers. We don't have the negotiating power that hospitals do, nor perceived facility costs that hospitals do. So I just want, like, the heading is hospital maternity units, and I think that there is definitely some distinction. And so if this is just hospital and we're going to do a second one on reform reimbursement policies for birth center care, either or we have to be more specific in these.
You muted yourself, Nashira.
Or if we need to be more specific here.
The birth center section does go into detail about reimbursement parity, and it talks about addressing freestanding birth center reimbursement, including facility fees, reimbursement for full scope of services. And the balancing part here is public and private payers should balance increased birth center payments across other service lines so as not to contribute to the overall healthcare spending growth. Kind of have that same line, but tailored to birth centers. Because we felt that the birth center reimbursement model is so different that we wanted to separate it out. To your point, we wanted it to be separate from hospital. Okay, and the share is happy.
Can I just emphasize this is not a question, or just for D, DPH is currently updating the hospital regulations as we speak to include levels of maternal care, with an anticipated promulgation this fall. So this is really timely. And just to kind of emphasize that this is going to go into effect really soon. So I think that there's a little bit of urgency to this.
Oh, great. Okay. All right. So if there are no additional questions on this item, why don't we move on with maternal health workforce?
Was there a closure piece or is
Was
that in
there-
the other opposite order in the slide? Sorry.
Oh, thank you. Thank you. I totally got a bit mixed up. Okay. So who had thoughts and feedback on these recommendations? All right, Lee.
Thank you. I think in 12, um, it- talking just given that a lot of these closures result from reimbursement and workforce challenges, just having some sort of acknowledgement in that sentence or in that recommendation or is important.
So to clarify, you're asking that we include an acknowledgement of the causes of closure?
Or, I think it's even maybe there's I don't know if I'm just thinking of the structure of how these work. So I don't currently in the reviews, but is there input from the Division of Insurance or Mass Health around or HPC, I guess, implications for, how a change in finances or potentially, use of the Maternal Health Sustainability Fund could
Prevent closures.
yeah,
Okay,
or
I see
used
what
as an
you mean.
intervention in a specific potential closure.
Mhm. Right, so this recommendation is all about interventions and what interventions we can leverage as the Commonwealth to prevent closures. And here it's suggesting that at certain points, certain transaction points, including when, the state reviews mergers, closures, conversions, and say, the Attorney General's office and all of the different sort of regulatory entities that, there are points at which we can kind of ask for requirements from the different parties of, say, the merger, or an acquiring entity where we can say you have to sort of keep a maternity ward open for a set number of years. So that this recommendation was around the times at which and the types of conditions that should be made for these when these transactions are going through. Does that make sense?
Yeah, and maybe my comments are better suited for the number 13 than to kind of
Okay. All right.
I did
So
have one other comment, sorry. In the documents we were given, that number 13 looked a little different, and there was a comment in it in the materials we got about providers should be required to file a confidential notice 6 months prior to the existing 180-day required public notice. And I just wondered if in your interviews with the closure hospitals, do you think that would be 12 months ahead of time? Is that enough time? If we are going to include that kind of specific time language in the final document.
We moved away from that recommendation. It's been discussed before and it's really not feasible. And so we just ended up, after a lot of discussion, we ended up removing it because of the issues you're discussing. Yeah.
thank you so much. So were there any other comments here, or Lee, do you feel like we sufficiently?
I actually didn't realize, I'm sorry, I'm reading my recommendation document, not the slide. So I think my concerns for 13 have been addressed.
Okay, I see. All right then. Okay, so I guess I'll put it out to the rest of the task force on the section on maternity unit closures. Were there any other thoughts or suggestions here that folks wanted to share? They're really just these two recommendations here.
Keep going.
All right, well, let's keep it moving to workforce. And I know there were suggestions here. So who wants to weigh in first?
Can we see the next slide, please? Thank you.
I believe there were some hands up for this one. Dr. Shields, did you have yours?
Sorry, not to hog the feedback here, but
That's okay.
I mean, I love the part about evidence-based anti-bias and anti-racist training programs for all providers, and that's something that, you know, many of us have had multiple types of these training programs over the last 5+ years, and in general, I feel like they're more focused on our interactions with patients and less on our interactions with each other and ways to support, you know, the other providers. So I just wanted to sort of understand that this language a little bit more, that the goal, as it seems written here, is that these programs are going to help retain providers of color. And I just wanted to understand that a little bit better.
There's a lot of data in the report about the sort of the makeup of the workforce and thinking about, just as you said, how do we make sure providers of color are excited about becoming providers of color, and how do we make sure that they have a successful career? And we went back and forth around this a lot just because of what is an evidence-based anti-bias, anti-racist training. That, you know, we tweaked the language, we removed it, we put it back in. And I think what we're trying to figure out here, and if people have better suggestions about how to word this, is how do we do that? How do we make sure that providers of color are supported, have a successful career, feel that they are leaders in their field and want to continue to be leaders, and bring in, therefore attract more providers of color. So I would love any suggestions on how we can write this in a way that really holds to that principle. And we don't have to think of the right words now. If people think about it and send it to us in writing too over the next few days, that would also be great.
Right. And also, if you think that these recommendations as listed here currently don't adequately really address the real barriers to having more providers of color, Black, Latinx, Native American providers in the Commonwealth, then we can also talk about that as well, because there are lots of other issues that come up in this space, also around the cost of living, a place like Boston and other parts of Massachusetts.
I feel like it's maybe I missed the language somewhere, but I think aside from just kind of like language and having provider of color, there's a cultural aspect, right? In terms of like culturally appropriate care, and that may vary from different kind of like racial population. That's one factor of it. But even within, let's say, the Hispanic or the Asian community, there are pockets of where birthing practices do vary. And I think that sensitivity, I think, would be important in providing quality and appropriate care. And I'm just wondering, is there a way to incorporate that aspect in the current language?
I'm wondering if that goes into the last recommendation that has to do with patient access. and
versus provide.
accessibility. It's about how to make patients feel safer in hospitals and be, you know, the piece around that. Just differentiating the training of, I liked how Sarah said it, more focus on the interactions with patients, less focus on the interactions with each other. So this interactions with each other as providers, interactions with patients.
Right, but the culture of the environment, I think, as Dr. True raised, is important there as well. So I think perhaps we can include some language there too.
Yeah, I like that a lot.
Mhm. Were there any other points of feedback on this section?
My comment was around, oh, sorry, it's number. Well, I think it's more explicitly in 15, but
Around midwifery capacity, midwifery education capacity?
Could I just make one comment on 14D before we? I'm
Sure.
just wondering if we could make this a little bit more prescriptive, this, you know, or a little bit more forceful. So increasing the flexibility to improve the adoption. I'm not sure that will incentivize hospitals to include more midwives. And I'm just wondering if there's any way that we could strengthen the language to really, again, not mandate it, but really, really strongly encourage hospitals to do this.
Yes, great point.
And I guess related to that, then I like the two halves of Part D recommendations, but I'm not quite sure why they're written together as one, because it seems like the second half is sort of a separate issue. So, and I also wasn't entirely sure what it means to implement adaptable staffing models to accommodate fluctuations.
Mhm, mhm. Yeah. Does any, Dr. Alonso, did you have clarity about adaptable staffing models? I don't think I.
Do.
Yeah.
And we're addressing this in the levels of care regulations, thinking about it. Rural hospitals where nobody's due in the next week, and we all know that. We live in a small community, we know who's due. Thinking about there are months where a lot of babies are being born and months where things are quite quieter. So thinking about that, just sort of thinking of those types of trends. Part of the concern that we have is how do we make sure that hospitals are staffed so in a way that they're safe, but also not staffed when there's nobody there. I mean, yeah, right. That's what I'm trying to say. We don't want to overstaff when nobody's there, and we want to make sure that when the hospital is full, there's enough staff and patient ratio. Amy, I see your hand up. I'm just going to
Yeah.
call.
Yep, I can speak to that. Staffing small community units are the hardest units to staff. Last week we needed 5 nurses, and we only had 2. This week we need 2 nurses. So we're in the process now, since the Leominster closure, where we're starting to get really busy at Haywood, and thinking of increasing FTEs, ways that we can do that when we need the extra nurses. We're in the possibility of thinking of adding an on-call system where once a week a nurse will be on call. So if we need to call that nurse in, we'll have the extra nurse.
All right, thank you. Relatedly, though, I think in some of our recommendations, going back to the hospital maternity unit section, in 10B, we also think about the issues around the types of financial support or revenue support, low volume, potentially rural units might need. And so we've asked that the legislature should provide support for these units. in reimbursement reforms and to study the feasibility of providing
Mhm.
standby capacity payments, for instance, as a way to ensure that staffing can continue to be available when needed. So I guess these two, we're looking at these multiple possible strategies, including how reimbursements can be changed as well as adaptable staffing models. So, all right. So I think folks wanted to weigh in on
I had one more point,
recommendation
sorry.
15. Yeah,
Oh,
go ahead.
sorry. I thought you were going to the next section. Sorry.
No worries. Yeah. So was your feedback on 15?
And I'm actually realizing it's not 15, but just a point that I think isn't reflected in the workforce section that might need a separate one or intertwined somehow in others. But to Amy's point, I think it would be beneficial to have a recommendation around investing or expanding labor and delivery nurse capacity.
Yes. Yes. Great point. Across the board or in specific hospital types, specific regions?
I mean, I think the need is most acute in more rural facilities.
Yeah, absolutely. All right. Great. Did anyone have thoughts about the point 15 about midwifery capacity? Do we cover everything here? Right. I know in the interest of time, we have one more section. No, we have two more sections. So why don't we move on to the section on freestanding birth centers? Right. I know folks had suggestions here, so who wants to chime in first?
My only comment on 17B is the reimbursement for full scope of services is needed for hospital delivering patients as well.
Yes, thank you. That I guess we didn't explicitly call that out in earlier recommendations, but certainly one of the earlier recommendations to sort of study the full cost of providing care was written with that intention in mind. So
I
we'll
would
make
second being explicit about that in the hospital section.
Yes, absolutely. We'll make sure that's in there.
Good section as well. Yep,
Mhm.
great.
All right. Okay.
Just a question back one slide, Dr. McGregor. What do we mean by further investigate? Like, what does implementation of that look like?
Great question. I'm going to defer to my co-chair.
So the legislature can mandate what Mass Health covers. The legislature can't mandate what managed care plans and what private payers. So that's why we need the Commonwealth to investigate opportunities, because how do we encourage payers to step up to the moment, and encouragement isn't working, apparently. We know that, you know that. So I think that's what we mean by that. If there's better wording, then certainly welcome to think about ways to you know,
I think we could do more than encourage fully insured commercial plans.
Does anyone have any thoughts or ideas there? So what would go further than encouraging? Would it be an incentive? Would it be a penalty?
Hmm.
Dare I say it?
I'll chew on it. I don't have a recommendation, but I would like us to be a little bit more pointed in this one. On it.
Okay. All right.
we will look into that. Great.
And then remember, as ideas come up, please don't hesitate to email. All right, that can't be it for freestanding birth centers. I know we had
Well, there's pieces on
there are
CPM
two more. Okay, perfect.
all within the ecosystem. Yeah.
Right.
Yep.
So on the workforce side of birth centers, we also include recommendations on helping to integrate CPMs into care. Certainly a very important piece of the recent legislation that we're all working to help implement. Did folks think that these recommendations adequately get at that? And I guess to the team, I see on 18B, we're saying that health plans should work to increase reimbursement rates for services provided by CPMs, sorry, that at a minimum align with mass health rates. And this is just a question, I'm not sure if anyone knows. Do we know whether potentially in other states or here that mass health would, not mass health, Medicaid in general might reimburse at better rates for CPMs? Do we have a sense from other states, I should say?
Have states where private payers won't cover CPMs
Okay,
and Medicaid does.
okay.
We have states where Medicaid doesn't. CPM regulation is so individual. And what we're trying to do with CPM reimbursement is learn from the mistakes that have been made with other provider reimbursements, so that at least when we say go and start the clock, we're starting with coverage that's dignified and covers the cost of being a CPM. We have a state, there's a state where CPMs get paid $100 more than doulas do for a course of care. And it's really impacted the CPM workforce.
Wow, okay.
Yeah.
So in that case, definitely the wording of these recommendations should be critical as well. And do folks think that the way that 18B is written is pointed enough and to achieve that goal or to get us close?
I mean, in other recommendations, we have measures of time. So I'm wondering, should work feels like a little passive, and I'm wondering if we could say, I'm wondering if there's something in there that we could say, either by time. I think we do say the other metric would be at a minimum mass health, but this is a bigger question for me about how we hold commercial health plans feet, accountable. And so I'm open to feedback on that, but I'm just wondering, a recommendation that they should work could be shrugged off. And I'm wondering what muscle we can, and I'm hearing you, Dr. Alonso, that there's not a lot of muscle that we can put in, but I'm wondering language wise.
Right.
Should, maybe it's even just should increase the
That's what I
recommendations
was
that you
gonna
should.
say.
Mhm.
Yeah.
Right.
Because I think that's the only one that's really modified in that way.
Mm-hmm.
The others just say should.
Mm-hmm. That's right. Yeah.
All right. That sounds great.
Great.
Okay. So if there are no further comments on this section, is that right? I don't want to move on too quickly because our last focus area was uncontroversial. Everyone agreed with with our recommendations on patient awareness and choice. So
Actually, could
but-
I?
oh,
Sorry.
go ahead. Yes,
I-
Dr.
In this conversation, sorry, I didn't mean to put my thumb up. I meant to raise my hand. But in the patient choice, I did have one comment that kind of came to me as we were having this entire discussion on the first point, the fund and launch public education campaigns. I would just like to put a plug in that we should also fund and launch a campaign. And I think this is being planned, but be more explicit about levels of maternal care. I do think what we don't want are very low risk patients to go to a level 4 just because they think, again, associate maybe a higher level with a better quality. So that's just my plug for that.
It's a great idea.
Yeah,
Thank you
I
for-
also think that there's a place to think about the opposite issue too, where people who may actually have some medical risk factors that would warrant a higher level of care might still feel strongly about choosing other than that care. And so I wonder how to, I'm assuming Pinquin has thought about that and rolling this all out, but that's one issue. And then the other is, again, to go back to the issue of insurance, because this comes up with, again, if an insurer says you can't deliver at my hospital, then, and that's the hospital where they need the care, that's a problem. So.
Right.
Yep.
That's right. Insurance networks can be a barrier to folks delivering at the risk appropriate setting. All right.
I also
So-
wanted to, Hong, when you mentioned about cultural practices, and I'm looking over these patient awareness and choice and saying that we don't have something that specifically calls out that recommendation that you had mentioned, and I'd really like you to help us articulate something around that for this section.
I mean, that sounds good. I think on the spot, I think it'd be hard to
Yeah.
think about something like where's the appropriate place also to include that language is what I'm thinking about, because we have the public education really center around in terms of hospital versus not versus like in terms of where do you want to deliver and by whom, with whom, right? Which is a little different than insurance coverage, and then there's the patient participation. So I'll take it back and then I will provide probably an email.
Yeah.
Be great.
Yes, thank you so much. And again, that goes out to the task force as a whole. If anything comes up that you want to add in and make sure is considered, please do email us in the coming weeks. And I think for the report as a whole, the feedback for that we're hoping to get by early April. And so we're almost there, but as you can tell by the number of recommendations we have, the work continues. So why don't we move on to the final portion of the meeting? which is to close out. And all right, so to close today, I just want to thank everyone again for your participation, for reviewing the documents. I know there are lots of details and we're covering a lot of different aspects of the health system. So thanks for your continued recommendations and continued feedback. We will follow up with you via email on the recommendations discussed today, and we'll recirculate a list of policy recommendations that incorporate your feedback for your final review before the full task force report and recommendations are published. And as we work to finalize this report, we'll be in touch with members to plan a final event to release the full report. And so I'll turn it over to Dr. Alonso for any additional closing remarks.
Just thank everybody who's here, those of you who sat through and watched us, and I'm sure had a lot to say. And those of you who did speak up, I'm really, it's just such a pleasure to be part of this group. I feel like we're going to come up with some very powerful recommendations that we know are really important to take very seriously. And I'm just really proud of the work that we're doing. And I'm also really aware that we'll be working on these for years, and I know how committed you all are to this work. So thank you. Thank you all so much. And thank you to the Health Policy Commission for your great organization of the slides, of the report, of sending out the emails, and just keeping us on task. And we did it with 5 minutes to spare. I can't believe it.
All right. And I guess with that, then the meeting is adjourned.
Bye. Thank
Great.
you.
Thank you.
Thank
Thanks,
you all so
everyone.
much.
Thank you.